Hi, my name is Chris Migliore. I'm a PGY3, and I'm the Director of Curriculum for Louisville Lectures. So over this year, we were hoping to do something called what is called at other medical colleges the Master Educator. So this is someone who is a clinician's clinician. I already warned Dr. Lederer I was going to praise her for about 30 seconds. So when clinicians don't know what to do next, they reach out to a certain cohort of clinicians at every institution. And I would imagine if I were to take just a kind of a snap poll here of all the attendings at Louisville and ask them who would you consider to be a clinician's clinician, I would imagine that Dr. Lederer would be on almost everybody's list. So I invited her to this format, and the Master Educator is also called Stump the Attending. What that means is I'm just going to begin presenting a case, and then she's going to talk us through how she is reasoning through this case. You're free to ask questions, but if you feel like you know it, if you do feel like you know it and Dr. Lederer doesn't know it, first off, kudos to you, because that's awesome. But the second thing is we will give you an opportunity after Dr. Lederer makes her guess on the final diagnosis, if you would like to guess as well. But if you feel like you know it, just to keep it organic and not to just kind of change the flow of thought for Dr. Lederer, if you could just keep that. You are free to ask any other questions you want during that time. The reason we chose Dr. Lederer, we actually hope to have, I'm not going to mention who, but we actually hope to have 3 other professors here over the course of this year come in for Stump the Attending lectures from different branches. One from GI, one from cardiology, and one from internal medicine. So the reason that Dr. Lederer was chosen, obviously, if any of you have had the opportunity to work with her, first off, she's very humble, which is a mark of an excellent educator. And second off, she's wicked smart, which is like super important because you saw in the last lecture she can go through things quickly. So with that, we will begin the case. Okay. So I did run this case by my mentors at my previous college, and there are some clinical pearls. If she doesn't mention them, then I'll bring those out at the end, and we'll begin. Okay, so this comes from Master Educator. The first one was considered to be Osler, and he has several quotes. He's the master of quotes, right? He wrote like 1,000 quotes. It helps a man immensely to be a bit of a hero worshiper, and the stories of the lives of the masters of medicine do much to stimulate our ambition and rouse our sympathies. I really feel like Dr. Lederer is someone who fits that description. And then if you read Osler at all, you know that the most important thing he did was teach medical students. He spent time with residents. He also spent time with upper-level residents, but the most important thing he felt like he did was he was continually teaching. And then my favorite Osler quote, of course, one finger in the throat and one in the rectum makes a good diagnostician. Actual quote from Osler, by the way. All right. So the chief complaint, I itch all over. What do you think? You hear someone say that.
Primary biliary cholangitis.
That's awesome. No. But what do you think when you hear that? When you hear I itch all over, what is the stuff that goes through your head first? How would you approach that?
I would get some more history.
Okay. All right.
Well, because it can be, any of the things that can cause hyperbilirubinemia. It is certainly a hallmark of kidney failure. It can be an allergic reaction. It can be contact dermatitis. There are many things that can cause itching all over. It's very nonspecific.
Okay. So this is a 60-year-old male. He presented to an outside clinic. He had a 3-week history of generalized pruritus. It started 3 weeks ago. It was originally able to be palliated with creams and lotions. It had gotten to the point where it had progressed, where it was constant. Now he was excoriated. He had excoriations in the skin. He had a cold about a month ago, which he said had resolved. And over about the last 2.5 weeks of kind of when the itching started, he noticed several weeks of fatigue and anorexia. Anything else? And there's a lot more information to give, but is anything new going through your head at this point?
No.
Okay. All right. Okay, so there's a previous medical history of chronic rhinitis and nasal polyposis. He had a left-sided hernia repair 10 years ago. He emigrated from Puerto Rico 10 years previous to this. No recent travel. He's a never smoker. He doesn't note ever using illicit drugs. He drinks socially. He is sexually active. His father died of kidney problems. He doesn't know what else that means, and that was several decades ago. He also has 4 healthy sons. Does this make you go down a different road or think of this case?
Well, the fact that his father died of kidney problems and he now has generalized pruritus, certainly would make me lean towards a potential renal disorder.
Okay.
Genetic, obviously.
Okay. Any questions so far? For allergies, he says he's allergic to NSAIDs. It was odd. He said he didn't know what happens when he ingests them, but he says he's for sure allergic to them. He says he hasn't taken any for several years. For medications, he's on a multivitamin. He also takes Flonase. Review of systems, positive for anorexia, fatigue, and occasional lightheadedness. Negative for fever, chills, vomiting, chest pain, shortness of breath, dysuria, no change in urine output, and he is not jaundiced. This is his physical exam. So you can see that the vitals are pretty unremarkable. He's well kept. He seems pleasant. He does have pretty dense erythema in his posterior oropharynx. Otherwise, there's no injection, there's no icterus. His neck is supple, there's no fibromegaly. Cardiovascular exam is normal. There was no JVP. Respirations are completely unlabored with good air exchange. Abdomen, non-tender, non-distended, no hepatosplenomegaly. Skin, appropriate turgor, and it's noted that there's no rash. That no rash can be found anywhere. An extensive search for rash was done on this gentleman. Nothing. 5 out of 5 strength in all limbs. He did say that he felt weak, but actually when it's tested, he feels he's 5 out of 5. No dependent edema, no asterixis, and he's outgoing lymphadenopathy. There is none noted globally. Anything?
No, but I zoned out on his medication, so if you could go back one.
Sure. Flonase and multivitamins.
Okay.
Anything?
When's the last time he was at a doctor?
So he hasn't been at a doctor for 5 years. Why'd you ask that?
Well, just curious if he had some known chronic medical problems that he was not, following up on or whatever.
All right. So the summary then, he has chief complaint of generalized pruritus, HPI. Oh, I gave a lab value without...
You didn't give me the lab.
Yeah, so that I actually would have gone there. This should have been after you saw that.
All right.
But, so I'll go to the lab, and then I'll come back to that.
Wow.
And we'll get a summary first. So we're going to go through basic labs. This is his BMP. So, med students, what is abnormal about this? Yeah, the BU and creatinine. So you can see at the bottom, 2 months ago, when it was taken for a physical for work, like a basic lab work and physical for work, completely normal, BUN and creatinine. And now he's at 130 and 9.2. Anything else on this? Say again. Yeah, sodium's a bit low at 130. Anything else? Calcium's low. What else would you want to know? Make sure that the calcium level is good, the albumin. And what else as you look at this? Probably an extension of the BUN creatinine. Interns can answer also. Potassium's at the upper limit of normal. Okay.
His phosphorus is extraordinarily low, considering what his kidney function is.
Oh, yeah.
He can't hear you, guys.
Oh, I'm sorry.
Oh. We tried to actually figure out 2 mics, but I guess it can't be done to record.
So I would say his phosphorus is incredibly low, considering his degree of kidney failure.
Okay, so this is his CBC. His segs are 44, EOs are basically 0, and lymphs are 39. Otherwise, when you look at this, his what numbers are close to being abnormal? Yeah, his white count is up, and his platelets are almost low. Okay.
How do we know his creatinine was normal 2 months ago?
So he had a basic history and physical, like with minimal blood work for a job. And it was known at that time that it was, his BUN was, I think, 15, and his creatinine was 0.8.
Chris, how old is this patient again?
This 60-year-old white male. Okay, is there anything else you'd like to see, or is there anything going through your head at this point?
Well, I'd like to see a urinalysis.
Okay. So 1+ blood, 3+ protein. There are 2 red blood cells. They're not dysmorphic. Fatty cast may have been present, but the actual report got cut off, so the end of that sentence wasn't able to be read. And there were no cellular or granular casts present.
Lipid profile?
So cholesterol 166, triglycerides 126, HDL is a bit low at 26, LDL at 100, and A1C is normal. Anything that you're thinking?
I don't think this is so easy.
Okay. Well, no, we're just, just the clinical.
No, I mean, it looks like the guy has at least some aspects of nephrotic syndrome, although not all of them. I take it from the data that we have that he actually has acute kidney injury with nephrotic range proteinuria. The nephrotic range proteinuria, I'm basing that on the fact that he is hypocalcemic and I presume hypoalbuminemic, plus has 3+ protein in the urine, although we don't have a urine protein to creatinine ratio to actually confirm that. Some surprising aspects are that, like I said, his phosphorus is not very high, despite the fact that he has pretty substantial kidney failure, which would point toward one of 2 things, either that he has a disorder that is giving him proximal tubule dysfunction and he's been phosphate wasting, or that his uremia has actually caused a decrease in appetite, so he hasn't been eating very much. The argument against that is that his potassium is 5. Usually, if they haven't been eating very much, the phosphorus may not be high, but usually the potassium is not at the upper limits of normal either.
Okay.
Were you looking for the triglycerides to be high on that?
Yeah, I was certainly looking for the cholesterol to be high, for certain, yeah.
Okay, so this gentleman, because of his creatinine 9.2, was admitted to the hospital. This was all I've gathered. Remember, he presented to an outside clinic. When he got to the hospital, he started developing edema. Okay. Is there anything else?
I guess did you develop edema because somebody thought he was volume depleted and started him on saline at 150 cc's an hour?
No.
Okay, just thought I'd ask.
No. So a workup was then begun for the creatinine of 9.2. Urine electrolytes. Okay.
Not very helpful.
Okay.
All right, actually, so I said that tongue-in-cheek because, we have a tendency just to sort of get them, just kind of drop kick, get them as part of the kidney injury workup. But if somebody is non-oliguric, and this has been going on for some time, then they're not going to be that helpful because their urine sodium is probably going to be relatively high or anyway. You can tell by the fact that he had a BUN of 130 and a creatinine of 9 that this didn't happen yesterday. I mean, this has been going on for a while, probably in his case, at least a couple of weeks or more. So he would, by that time, even if he had developed some fixed kidney damage, he would probably be in sodium balance, and therefore whatever he was eating he would excrete. And so for that reason, the urine electrolytes in this situation, like I said, are just not going to be that helpful.
Okay, to give you an idea how good Dr. Lederer is, that slide was included because they don't provide any information whatsoever to the case, but because you just get them because, they've got kidney stuff, so we need urine electrolytes. So well done on that.
Thank you.
That was awesome.
I guess I passed test number 1. I get up to the next level, and I can just...
That was awesome. Okay, so they also did a workup then as to why the creatinine was high, and they gathered a renal ultrasound.
Plot definitely thickens. All right, so this, to some extent, it would not have been a surprise if his kidneys were described as normal in size, because supposedly 2 months ago he had completely, normal kidneys. But renal enlargement starts you off down a different path. And when you have acute or subacute kidney injury with enlarged kidneys, then you think about certain entities. Multiple myeloma, other plasma cell dyscrasias, infiltrative diseases of the kidneys such as amyloidosis, even sarcoidosis. Sarcoidosis is usually an interstitial disease. However, it can be complicated by membranous nephropathy and even IgA nephropathy with nephrotic syndrome. So something like this would be a consideration. Another consideration would be renal vein thrombosis. So we know that renal vein thrombosis is a complication of nephrotic range proteinuria, and even though I don't have evidence yet, that this guy is frankly nephrotic, this would be a consideration. Another, I'm sorry, let me just complete that thought. You would generally expect to see some hematuria. 0 to 2 RBCs is, which I think is what showed in the UA, is not very much. You would expect to see more hematuria than just that if they did have bilateral renal vein thrombosis. And you would have to postulate that he had a bilateral renal vein thrombosis to have kidney failure of this degree. And I've forgotten, I was going to say something. Oh, okay, so the other thing to consider is HIV nephropathy, which in its early stages can also give you enlarged kidneys as opposed to small kidneys. He was sexually active. You may think to yourself, 60, isn't that old? But it can happen.
All right. So we'll do Immunological Panel. So complement levels were gathered. They were all normal. Anti-streptolysin was positive. A throat culture was positive for group A strep at +3. HIV, Hep B, and Hep C were all negative, and parvovirus B19 was negative.
Okay, so this is looking very much like I shouldn't say post-infectious, because this is almost simultaneous with infection, acute kidney injury. Certainly in adults, the acute kidney injury with the glomerular picture that you see with infection can be very different than what you see in children. So in children, your classic history, for example, of post-strep is they have a sore throat or skin infection. 6 weeks later, the dark urine, the hypertension, everything else. In adults, you certainly can see that. It's not that you don't have to see that, but they also tend to have more co-infectious GNs that are characterized by the lack of hypertension, which he didn't have, which you usually see with post-streptococcal glomerulonephritis, and a more prolonged course that is dominated by nephrotic syndrome. I'm still a little bit surprised that he would not have a more quote-unquote nephritic-looking sediment, but you can see just basically a mostly nephrotic type of picture with adults who have post-strep.
Okay. So a 24-hour urine collection was gathered. He urinated 1,400 mLs over 24 hours, and there were 23 grams of protein in it.
That is a lot. He definitely has nephrotic range proteinuria, and even though it looks like, I'm sorry, could you go back to the last slide?
Sure.
So even though this, like I said, is beginning to look kind of like this could be something like a post-strep GN, I think in this age group, et cetera, and also because of the phosphorus, I would also get an SPEP on him.
Okay, which was gathered. Okay.
Yes?
How long ago was this pulled?
1 month ago. Thank you for air quoting cold, by the way. That was nice. All right. And a rheumatology panel was gathered as well, which that's obviously not a rheumatology panel. So we'll scroll through and find it.
An ANA of 1 to 80 in somebody this age is not that significant.
That was another teaching point, by the way. I'm going to have none left at the end. That's awesome. Okay. So we'll go to the hospital course. The patient was immediately treated with corticosteroids. Rapid improvement was noted. The patient was able to be discharged 3 days afterwards. Several years out, the patient still has mild proteinuria, but it's not nephrotic range anymore, and then minimal peripheral edema.
Okay, well, I have to admit, it was certainly not the next slide I was expecting. All right, did he have a kidney biopsy?
He did.
And actually, let me just say parenthetically, I would have biopsied this guy.
Yeah, a biopsy was gathered. So because I didn't have rights to the biopsy, this picture was deemed to be equivalent to the biopsy picture. And this is what came up. And they even did an arrow.
Okay, so yes, this is a kidney biopsy. Just looking at it overall, I would not consider this an adequate biopsy unless I'm just blind. I only see one glomerulus. There may be a little bit up there, but I'm not sure that's a glomerulus up there. But I only see one glomerulus, and it's at the very edge of the biopsy. Usually what you would like to see in a good biopsy specimen is you would like to see 10 to 20 glomeruli, and ones that are kind of in the middle. If I just overall look at the impression here, you can see that as opposed to a normal kidney tissue, where you would see the tubules being back to back, you can see some areas there where they're, for example, kind of in the middle, almost at 12 o'clock, there are 3 tubules cut crosswise that do look like they're back to back. You should expect to see the entire cortex looking like that, and you don't. There's a lot of space between them and a lot of interstitial infiltrate with some type of, at this magnification, looks like mononuclear cells. So I would certainly entertain a diagnosis of interstitial nephritis, at least as being one component of what this person has. From this magnification, I can scarcely say anything about the glomerulus, except that it appears that it does have a loss of capillary loops, an increase in mesangial matrix material, and other than that, I really can't say much about it.
Is there anything that you would then, that tends to give that picture pathology-wise?
Combination of glomerular disease with interstitial nephritis. It's pretty classic for lupus, which I don't think that this guy would have, although, lupus can present in males and even when they're older. You can see this actually with non-steroidal anti-inflammatory drugs. You can see that. As I mentioned, you can see that with other interstitial diseases such as sarcoidosis. Generally with post-streptococcal glomerulonephritis, you do see the glomerular changes, but interstitial nephritis is generally not a huge component. So you would have to propose that maybe he did have post-strep, but then on top of that got an antibiotic maybe that gave him his interstitial nephritis.
Okay. What are the different types of post-strep things that can happen in the kidney? Is it just post-streptococcal glomerulonephritis, or can anything else happen with strep?
Well, generally, the acute glomerular disease associated with it, is by far the most common. However, it is also very well known that some individuals who get post-streptococcal glomerulonephritis as an acute event actually go on to develop a chronic illness, or the acute post-strep does not completely resolve, and they end up then with some chronic kidney disease. But definitely by far the most common is acute GN.
Okay. The fact that he resolved on steroids, does that point you towards a final diagnosis?
If what they're trying to show there is that maybe he has focal sclerosis, certainly a course of steroids would be useful. I mean, this obviously does not look like minimal change disease, which you would expect, to resolve very quickly with steroids. There's really not much in the way of glomerular diseases that resolve that quickly with steroids. Minimal change will. Focal sclerosis will resolve with steroids, but it takes a much longer course for that to happen. And to my knowledge, there is no good evidence for the use of steroids in any type of a post-infectious GN.
Okay. So one of the other teaching points was that I had the person who sent this slide to me claimed it was equivalent, so I sent it to one of my old mentors, and they said this is a poor slide because it just doesn't meet requirement, and no nephrologist would feel comfortable looking at this slide and actually making a diagnosis off of it. So I didn't have access to any other slides. I feel like if I would have been able to show what the slide actually was, it would have been very straightforward, but you actually got there anyway. So we got an MRI. No, I'm kidding. All right. So would anyone like to add anything or ask any questions at this point?
Was the nasal discharge the primary discharge bloody, or was it just, fluid, snot?
Just snot.
Just
So this gentleman was diagnosed with focal segmental glomerulosclerosis. They had a collapsing variant, actually, so it was very aggressive. They said it was likely preceded by a viral infection. It was. They don't like, so no one really likes calling anything idiopathic in nature because it means that you don't actually know why. They think that even though he was positive for strep, that there could have been a viral component on top of that, especially because he has a chronic symptoms of URI, and it may be hard to know if there was an actual upper respiratory infection present. But you mentioned the sclerosing, so the focal sclerosing, which is what it was.
Yeah, I'll have to say, so if this had been my patient, I would have gone back and retested him for HIV.
Because of the false negatives.
Mm-hmm. And the fact that, that this is the collapsing variant of focal sclerosis is pretty classic for HIV nephropathy.
And it was actually, and that was the last pearl. It was actually mentioned that they would have repeated this. He did respond quickly, and they took the original HIV at face value. But you can have, is it 1 in 5,000? Like a 1 in 5,000 for false negatives on HIV. 2 false negatives is virtually like a statistical improbability. So they would have repeated because usually you get a collapsing variant within HIV. But of course, Dr. Lederer did get to focal sclerosing, which was even with a bad biopsy, she was able to get there. So, any other questions? Okay, so we're going to have 3 more of these this year with some other professors who are the same, we consider the same caliber as Dr. Lederer. Thank you very much.
Okay, but can I just make
Sure.
a couple of comments? Okay, so first of all, I was asked to do, I told Chris I was asked to do a CPC once when I was at Baylor, and I got it wrong. It was the old New England Journal of Medicine style, where they gave me a case, I've forgotten, it was like 2 weeks before the grand rounds, and I presented the thing at grand rounds, just like you read in the New England Journal of Medicine, and came up with the answer that this guy had a vasculitis, and that was the cause of his death. Well, as it turns out, the guy had disseminated mucormycosis. There's no way on earth that I would have gotten it. And yet, on the other hand, what I realized was that, so I had stopped in developing my differential diagnosis at vasculitis, when in fact we know that there are many different variants of vasculitis. And if I had simply thought longer and more fully about it, I would have at least been able to come up with this could potentially be an infectious cause of vasculitis, because you guys remember that Bucor is one of those fungi that actually grow along the arterioles, and cause a vasculitis, and that's how they kill. So Chris asked me to talk about critical thinking, and I'm just going to show. I just have a couple of slides here, because it actually occurred to me it's really, really hard for me to explain to people how I think. So this is the best that I could come up with. Okay, now this is not as weird as it looks. So generally, if I'm confronted with a patient, and this one was pruritus, but it doesn't matter what it is, chest pain, abdominal pain, shortness of breath, or whatever, and I'm rolling on the way down to the emergency room, I already have this differential diagnosis that's ticking off in my head. And I start off thinking very, very broad and fuzzy, just kind of big, broad categories, and not even all of them fitting exactly within the realm of, say, chest pain. Then, as I talk to the patient and I examine them, then these crystallize into some possibilities that are substantially more likely than others. So, this is supposed to represent my more crystallized thoughts, okay, that are more specific. And with more data, then I come up with problems that I can actually act on. And that's, so I go from thinking that I consider, quite frankly, very vague and circular, to thinking that is more linear. Okay, I'm going to go from this to this, this to this, this to this. But I recognized in, the way that I do this is that the first thing I do is to listen to the patient completely. You're going to get a lot of red herrings. You're going to get a lot of talking around like this, but you got to listen to everything that they say. The other two things that are really, really important for you guys to know, and actually it was beaten into me, well, not seriously, but it was emphasized to me when I was a medical student and resident, is that you have to know how diseases present and what their natural history is. And I used to have to, I can remember when I was, we presenting a case, and my attending would ask me, what is the epidemiology? What is the demographic? What type of person usually gets this? How often do they have hemoptysis, let's say? So, if you had a 30-year-old who came in with chest pain, an MI is not the first thing you're going to think of because of the demographic, right? And also to know the natural progression of the illness as well, because if somebody tells you something, it started off as this, and then it did this, and now I have this, there are certain diseases that progress this way and others that don't. And then finally, you have to have really an organized and consistent approach to obtaining data. And by that, I don't mean that for every single person with chest pain, that you say, okay, I'm going to get a chest x-ray, I'm going to get an EKG, I'm going to get a CT, PE protocol, I'm going to get a CT of the whole chest, I'm going to get an echo, I'm going to, no. You do this in a very, very directed fashion, but you have to have an organized and consistent way that you approach it. So, from the history, I can tell you what I do is I go to the physical exam that includes some key differentiating aspects. So this guy had acute kidney injury, and of course I didn't know he had nephrotic range proteinuria, but acute kidney injury, it sounds so dorky, but even now, with as many years as I've been doing this, I always go in there thinking, could it be pre-renal, renal, or post-renal? And I'm asking the guy questions, and I'm doing the physical exam to, in my mind, include or exclude certain diagnoses. So, acute kidney injury in somebody who has a family history of kidney disease. Obviously, I'm going to do this great physical exam that's going to look for big polycystic kidneys. I'm going to listen to his heart and see if he has any evidence of aortic or mitral valvular disease. Even though somebody else got the history, I'm going to say, hey, did you ever have a problem with diverticulitis or diverticular disease, diverticular bleeding? Has anybody in your family ever died of a stroke? Have you ever had an intracranial bleed? So I'm going to be asking questions like that. I'm going to be asking questions relative and looking for the exam for his hearing. Could this family have autosomal dominant Alport syndrome? It would be sort of a late onset, but I can't absolutely exclude it. Then, again, review the lab, the x-rays and everything with the differential diagnosis in mind. And then I always construct a huge, giant, inclusive problem list. Everything. Absolutely everything on there. Just in a line. And then I go back and I consolidate and prioritize my problem list. So in this guy, it would have been, when everything was said and done, we started off with pruritus. The poor guy, that's what he came in with, was, his major complaint. Then I'd start off with acute kidney injury, nephrotic range proteinuria, sore throat or cold, whatever it was, 1 month ago, pruritus, relatively low phosphorus, et cetera, down the line. Then after doing that, then I take a look at the problems that I think are more pertinent to whatever I was asked to do. And in this case, the guy was looking at his kidney failure. And then identify what additional data that I need and what immediate therapy this guy needs if indicated. And all of that extra data is simply to either continue to include or to exclude different things on the differential diagnosis, and then come to a decision. So let's just say that I came to the decision on this guy that what he had was post-streptococcal glomerulonephritis. What were the pieces of data there that made me feel kind of a little bit uncomfortable with just landing on that diagnosis? Well, C3 was normal. He wasn't hypertensive. That's not, you can get that in adults, but it's not that common. His urinalysis was just about as bland as it can possibly get. There was nothing nephritic looking about it at all. And so at that point, I would have realized, although this seems to fit best historically, with post-strep GN, I need a biopsy. I need a biopsy actually to tell me what's going on here. So, that is your validation of your decisions then, is that, you do the biopsy and I say, ooh, I don't think this guy had post-streptococcal glomerulonephritis. It looks to me like maybe he has, a collapsing variant of focal sclerosis. And then treat him based on that, see how he responds. If he responded appropriately, then I'd say, well, I probably came up with the right answer. If he didn't respond the way that I thought he was going to respond, then I'd go, whoops, I need to go back. I forgot something. I didn't ask about something. I didn't take something into consideration. Now, I would submit that this guy had focal sclerosis for a long time, and that the chronic interstitial findings on his biopsy showed that he had focal sclerosis. And then remember, not every single person who has focal sclerosis has a huge, awful, rapidly progressive picture. Not everybody does. Why or what triggered him to develop a worse picture, I don't know. The fact that he responded to corticosteroids, quite frankly, suggests to me that he did have either a drug reaction that gave him his interstitial nephritis, or perhaps an infectious, like I said, even sarcoid for that matter, would respond that well. And you don't always see the granulomatous lesions, of sarcoidosis in the kidney biopsy. So that was it. It was a great case. Thank you.